Today I'm going to talk about the drug resistance and some dynamics of drug resistance, some pattern of it, and I have some kind of a toy model to understand the mechanism behind the emergence of drug resistance at population level, and I mean what can be done for that, etc. Kind of prevention, etc. Okay, but before that, I would like to um, like talk about like what I do there in my lab. So it's a disease modeling laboratory, and I mostly work on different work at the interface of disease and human behavior. We mostly work at different kind of disease, like for example, influenza, infectious disease. Influenza, TB, malaria, dengue, COVID, and also drug resistance. And we look at like analyze human behavior in context of three different pillars here, mostly the demographic, socioeconomic, and environmental. But demographic, for example, we look at individual contact pattern in a city, how it actually helping to transmission, or say, for example, say opinion sharing. Okay, for example, during COVID, we had a lot of opinion sharing about vaccination, how it has impact in vaccination dynamics and the choice of vaccination kind of thing. Also, age structure in a city, how it helps in transmission, and the migration. So migration from one place to another place. In fact, during COVID, a lot of migration. These workers, they come from village to city. I think it happens in every country, and that has a lot of impact on the COVID transmission when there's a lockdown and and social isolation. In fact, here I collaborating with the Professor Ina on this some kind of migration and its impact on malaria endemicity in sub-Saharan Africa. Okay, so I also work on socioeconomic aspects of, for example, ITN use and its impact on malaria. So self-medication, for example, there's a lot of self-medication and over-the-counter drug use in low and lower income countries, especially in India, Pakistan, Bangladesh, and also Africa. It has impact on a lot on the drug resistance. And that is what I'm going to speak today. Okay, and treatment seeking behavior, that is we do for the TB. We have, I mean, uh, we are lot of data in India for different kind of disease that we use to explore, in the interface of human behavior and develop model and things. And recently, I have started with working on CVD, diabetes, and lung disease, and kind of the impact of air pollution on this thing. Okay, especially in Delhi and places, there's a lot of pollutions. Okay, and we do mathematical and computational statistical tools here, mostly game theory to describe, human behavior, dynamical system theory, optimization, statistical inference theory, and also complex networks. And recently, we are moving towards machine learning because we have a lot of data, and from there we extract pattern, and then we embed game theoretical model in it to answer certain questions, biology. Okay, with this, we start now to this lecture. So this is what you say here. See here is the study kind of a estimation by Rand Corporation on the deaths attributable to AMR, and with compared to with other potential cause, for example, cancer, cholera, diabetes, and measles, etc. And what they say that if the resistance, say that. If the resistance, the drug resistance is left unchecked, 10 million more people would be expected to die every year by 2050, and will be producing, world will be producing between 2 to 3.5% less than it otherwise would. So there's a lot of impact on this. And here is like the global picture of the death due to AMR. This is an estimation, and it's, as you see here, that this Middle East and India, South East Asia also has lost a lot of death, and it says that this study says that the importance of not only treating the infection but also reducing and controlling AMR globally. Okay, so we also treat infections. Of course, this is costly, but at the same time, we have to see how we can control and reduce the AMR resistance. So for that, we need to understand the cause for this thing emergence from the population view. Okay, so I know most of you know about what antibiotic drug resistance is, but still, I would like to highlight here how it basically emerges. So, in an ideal situation, we have a high number of bacteria in the high number of wild bacteria, the blue one, the bacteria, and in few of them are resistant to antibiotics. Okay, but when we start, this is the kind of a natural selection. This is the ideal situation in the community. But when we start a lot of antibiotic overuse and misuse, it changes the selection pressure by killing them or good bacteria, and that changes the selection pressure, and that can helps to multiply the resistance bacteria. And that is how it actually infect or transmit to other people. And sometimes what happens, there are a lot of plasmid transfer, even more severe kind of infection can emerge because of this genetic exchange between wild and the resistant bacteria. So this way, I mean, this is not very kind of detailed mechanism, but the overall, this is kind of the process happens. And once it happens, then the transmits through different kind of activity, from the hospital and food and livestock, and it spreads through the community. Uh, okay, so this is the situation now here. Um, uh, the main thing is that now, as a researcher, we are here to take this question: what is fueling the world's antimicrobial resistance crisis? Okay, so this is the recent story by in the United Nations website on chemicals and pollution action. It says that there are five major causes that is actually fueling this crisis. One is the most one is the contributing one is the misuse of antibiotics in healthcare, livestock, and agriculture. And the second one is the lack of access of clean water and sanitation, especially the focus for the poor, low and lower income country in sub-Saharan Africa, and also remote areas in India and Pakistan, Bangladesh. Of course, this war and wear and thing that it's bringing a lot of kind of thing, lack of access, and the pollution from pharmaceutical companies and farming. So, like I can tell you, this water pollution is increasing day by day, water and air pollution, because of this the waste from these pharmaceutical companies there, and mass movement of people. This is another interesting thing which was not earlier, but these days there are a lot of people are moving from one place to another places. You see, this movement from one country to another country these days is really kind of is not a matter, and that we have seen the impact of this in COVID, during COVID, you know. And the last but not the least is the climate change and the biodiversity loss. We are in face of flood, drought, and there are many kind of climatic disaster, and that changes the biodiversity, and that ecological the pressure that it's imbalancing the selection pressure, and that has a lot of impact on the drug resistance. So these five reasons are the most important here, and I'm going to talk here about the misuse of antibiotics in healthcare by self-medication. We'll come to that more towards that. Okay, so here, before I go into that, I will speak mostly the overview of the problem, the model formulation, and the results, not really the model analysis here. Okay, so here what you see is the countrywide antibiotic consumption and drug resistance index. As you see here is the drug antibiotic consumption. For example, if we say this is DDT, this is the unit per thousand individuals, the color code here, and we have seen the India is the blue one, but the India population is very high. And if you see here, the drug resistance index, India was kind of in the highest in the rate here. And because the study I focused of the Indian data, so that is why I focused here. And as you see, a lot of different kind of drug resistance is there. This is indicated by the color code. Okay, and so this is the recent study by CDEP. This is one of the research-based companies there in Washington. They have their main office in Washington and in also India and maybe in other places. So it is their analysis. And here is the situation in India. See, what it says that it's 250 pharmacies pulled up for selling medicines without prescription. So in India, one can buy antibiotics without prescription. And it's very common here. It's not only in India, most of the, I believe, lower income countries, this is very kind of easy thing buying antibiotic. Here it's not possible, right? No, it's not possible. Not even US and Canada. I was there, so I know. But this India, it's really doesn't matter. Okay, and as you see here, it is always kind of crowded pharmacies. You know, they don't go to the doctor. Even they go to the pharmacy in the community, and they say, okay, just I have this problem. So and pharmacists, they give the advice. Okay, you take this medicine. Probably they also, I know, make a profit, so they also encourage, to do that. But of course, this is not legal, but things are happening. This is the situation. And here is the result. It says that this is India has increased that antibiotic use, this from 8 billion pills to 12.9 billion from 2001 to 2010. This 62% increase of self-medication by this thing. And China is 10 billion and US is 6.8. This is the antibiotic side. But India is always high on antibiotic use. This is the case here. And here is one particular, I would say, antibiotic use I'll focus. This is carbapenem and cephalosporin. Carbapenem are a class of beta-lactam antibiotic, and this is kind of effective for Salmonella, E. coli, Mycobacterium tuberculosis, Marsan kind of thing. But also it is resistant to several bacteria infection like Klebsiella and A. baumannii kind of. And cephalosporin, also a class of beta-lactam bacteria. It is mostly treated against skin infections, soft tissue infection, meningitis, but several gram-negative bacteria resistant to, such as E. coli, is resistant to this. So this, if we see, this is the study by the same, this is a group, I think this is in US based group, and they have studied estimated the coverage of carbapenem and cephalosporin here, and the prevalence of A. baumannii, which is resistant to carbapenem, and E. coli resistant to cephalosporin. This is the picture here. Also, if you see, the India is also scoring highest in this too. So it, of course, this study was obtained using entire World Bank data set of this standardized metrics. I mean, a lot of socio-economic, socio-ecological, and different metrics, income, etc., demographics. So that using these metrics, they have estimated this one. Whatever, it says that India are on high this thing, and not only India, mostly lower income countries also shows kind of the same kind of they are on the same scale. So here are the changes in the antibiotic consumption in India. Okay, some of the antibiotics, of course, there's a decrease, but at the same time, there are antibiotics which are on higher higher portion of these things, especially this group carbapenem here, as you see. Okay, the interesting thing is that this data says that this is E. coli and Klebsiella pneumonia. This is the resistance, the increasing from 2008 to 2018. They're constantly increasing, and this is the sales volume. Okay, for the pharmacy, it's not under prescription volume sales. This is just sales from like over the counter. Okay, this has increasing a lot of, I mean, over the this period. So that is kind of the increasing burden of overuse and misuse of these antibiotics that is being happened here, and a lot of prevalence of this disease also happening here. Okay, so what we have the data for different states, because in India, the if we I'll show you the data, the socioeconomic factor. If we classify this thing, it's very different. You say in Delhi, or if you go to remote places, like it's very different economically, demographic also, population wise, and that is why that has a lot of impact, as you'll see here. So as you see that some states shows very higher range of antibiotic use, education, exposure to media, that have a lot of importance, and some states shows they have kind of on the negative side. What we have done this thing, we have plotted the data with this human development index, and human development index depends on different socioeconomic and sociocultural factors here. When we plotted them, we see there's a clear kind of a pattern it shows. Like, for example, there's a high development index means lower antibiotic misuse, where there is a lower human development index, there is higher things, antibiotic misuse. So these thing also tested, like here it is for part socioeconomic factors. We have plotted this thing. This is media exposure, per capita expenditure on education, literacy, population below poverty line, per capita income. And as you see here, in everywhere, it shows the one thing that with low education and lower income, lower media exposure is actually certain increasing factor of higher antibiotic misuse, like through self-medication, especially in healthcare. I'm talking about, not in agricultural or the livestock use. I'm talking about only the health culture portion. Okay, so yeah, higher with things. So here what I have done is there is a one study, prevalence and predictors of self-medication practice in India. This is a kind of a meta-analysis kind of study. So what it does, it has accumulated different study of self-medication in different places in India, especially the states with lower education, with lower income, per capita income, etc. And as you see here, the average, it says the 50% of self-medication all over the India. And this is only focus socioeconomic group, is this is the middle uh, income. Here is the medication type, mostly antibiotic. There's a large variation in this thing. And also the reasons, they're mostly on the economical is the most one. And at the same time, lack of awareness and education also shows there's a high variation for this type of self-medication. So with this kind of, we have this bits and pieces information from the data, and what we kind of understood, we joined them and tried to understand that this drug resistance, like from the healthcare or human behavior perspective, it is a twofold problem. It is increasing the global burden of infectious disease by increasing the chance of emergence new pathogens. That is obviously it is doing, but at the same time, it diverges the economic growth of nations worldwide. For example, if you see the poor, the slums area in India, they are actually the most sufferer, because their the lifestyle and lack of, for example, the sanitation, clean water, and their lifestyle, it actually increasing the transmission of the disease. So they are the most suffer of the disease. They don't have money to take the treat this thing, and once they trap in this disease, it is actually impacting a lot of economical kind of conditions on them, right? They don't go for this the job, and they lose their money, and they are even become more poorer, and that change their habit. So this kind of vicious cycle that present in the society. And as you see here, this, and we call the mathematician as a feedback system that is being the creating here. Okay, so what we tried is, or our lab tried is, we tried to model this feedback system. Okay, so here are we have components here. So antibiotic overuse, as you see here, we have we have used the same kind of a pattern what you see with human development index. That is, higher income on the right side, it means lower antibiotic use, which is the y-axis. Okay, and we have also, like we we have also the infection dynamics. There's another component here. So we have susceptible human, susceptible without antibiotics, but susceptible with antibiotics. Those who are taking antibiotics without any cause or reason, they even don't know what their reason is, but they're taking just antibiotics, just buying the over-counter medicine and taking antibiotics. These are people. Now, this is the wild bacteria and this is the resistant bacteria, and there are a lot of interactions between them. So this is infection dynamics. And then we have also economic growth, because as I told that it impacts on the economic growth of the society, and that we have incorporated here. So in economic growth we have a capital and the production, and the usual kind of the structure here is the Cobb Douglas dynamics here. So we have equations for infectious disease, we have equation for the antibiotic consumption, we have equations for the economic growth. What we have done, we have combined them to develop a complete model and to analyze certain things here. Okay, I'm not going to the analysis things, but the interesting results what you see here. So we have a two strain here. One is the wild strain, which is relatively good. We say no problem, but okay, make little problem, but the resistance, which is the more severe, the harmful one. Okay, and we have characterized or analyzed under what condition the resistance strain emerge into the community or in the population. As we see here, the persistence of sensitive strain, yeah, also depends if it crosses some kind of a threshold, which is a function of antibiotic use. That is the most important thing. And as you see here, in this case, this is called the threshold of the community-wide antibiotic utilization. It means that this is the threshold. This is, I mean, one can really calculate, okay, this is the community, this is the number of people. Then for this disease, this much antibiotic one can use, not more than that. If you go beyond that, then possibly we are changing the selection pressure with this wild bacteria, resistant bacteria, and that can give you the emergence of resistant bacteria. So this is in terms of the model parameter, which involves the antibiotic use and economy here. We have also looked at like relative fitness and coexistence, at what regime of your antibiotic use, okay, both resistant and wild bacteria coexist. If you go less, then of course only wild bacteria. If you go beyond that, probably at the some time point, that resistance bacteria will emerge here into the system. So this kind of analysis we have done, and it says that at higher relative fitness and higher values of antibiotic use, only the resistance strain persists, wiping out the sensitive strain from the community, which is called competitive exclusion, we say in ecology. Okay, so that is what we have done using model. And here some of the simulation shows with economical aspects. For example, if we compare it in higher economical society or poor, here this is one model variable. H is the economy, H0 representing the higher economic country. Okay, so as you see here is the graph. It says that for lower economic country, the graph, the line over here in the left side represents the lower economic, and it means that it takes very less time to emerge it or to stabilize this, the resistance into the into the population, whereas for higher income country it takes longer time. Say for example in month 60 months it takes, whereas for poor it takes 10 months to emerge and establish the resistance pathogen in the population. So it depends on kind of a economical perspective here. Okay, and here also we have plotted with the volume of antibiotic use and duration of antibiotic use. It says that volume of antibiotic use has a lot of impact. That is what we see in the India. In India, we have seen that the rate, if you can recall that figure I said here, the rate is very low for India because its population is very high. But if you come to the volume, we are the highest one in India, and that has a lot of impact. That is why you see a lot of highest resistance in India. So this kind of model reflect kind of what we see in the data. Okay, so now thing is the financial support and controlling drug resistance. So what we did that, suppose if government helps, so if so this param term actually indicates the cost for treating the infection. So that is the loss of economy here. Okay. And now in that, if government helps, so what we have done, we said that suppose the cost of infection per capita cost, it decreases, okay, with more number of the patient here, because of government gives subsidy, some kind of, okay, going to hospital and treating, you don't have to pay anything. In that case, what we have seen is that we can reduce this the resistant population by doing that. And also the we can improve, the income, and antibiotic consumption also reduce. So this is the practice of the lower economic population, and that can be changed by giving subsidy or incentivize from the government. And the main another point is that the red arrow here means that government needs help as early as possible. Once the resistant pathogen established in the community, it really doesn't help much to, get removed from the society. As early as possible, government should help in this thing. So it says that early and sufficient financial support can improve the situation. So we, and now to check the model, whether it is reflect or any data on things. So this is the data. This is the prevalence of this E. coli and Klebsiella data, third generation resistant Klebsiella data from worldwide data it is. And um, and we have plotted against gross national income per capita, and these are the different countries here. What we have done with this data, of course, to verify our model, we need very granular data, very high resolution data we required, which is very difficult to get it, because survey data mostly either it is a missing, or I mean, we miss something which were required. So what we have done it, we have done some kind of a statistical thing. We use some Gaussian mixture model kind of to cluster it. And what we have seen here is that our model sort of predict the two clusters, higher income country, lower income country. Lower income country for two different pathogen here. Lower income country, sorry, this is the lower income country, has higher kind of a resistance for these two. But our model kind of a prediction with some value here, it can predict the nature of this dynamics, overall dynamics in the phase space. Okay, so with this this work has, we can summarize here this combined impact of economy, infections, and self medication practice in synergistic interaction, presenting the emergence of drug resistance as a self reinforcing cycle. That is what I said, it's a vicious cycle is there, kind of one is pushing another, it's a self reinforcing. And proper risk communication, health awareness, and education might need to reduce the antibiotic consumption and to stop the emergence. And timely public health support might help better. Okay, so these we have published in scientific reports in 2019. Now we went to the deeper of this, like as you see this a pattern, kind of say higher human development index societies or say states shows lower thing, kind of what is called lower antibiotic consumption rate, whereas the opposite for the kind of the situation in with lower awareness or lower income countries or states. But if we think about from the individual perspective, what actually kind of compel us to go to pharmacy but not really going to hospitals? That is what we are going to try to look at. And there, so this is kind of the situation. For example, when you get sick, so you have two options, for example, say, okay, either you go to the pharmacy or go to the hospital. Pharmacy, of course, I mean, there are costs. There is, you are not going to lose any kind of your, of course, this is a situation for lower income country. You're not going to lose any job or one day job or etc. But at the same time, you have no proper treatment. But if you go to hospital, it's a costly. You'll get a proper treatment, but costly. So whichever the options, you have some kind of a cost and kind of a benefit there. Okay, and these kind of thing reduced to some kind of a public good game. Like for example, the public are using city transport. Few people are there. They want to use the transport system without paying the ticket, and they have the kind of idea, okay, others are doing the ticket, so the system will be more sustained, no problem. I just don't pay the ticket and I will travel from the place where I require. So that is kind of the situation here. Like I'm not going to the hospital, so I'm not, because I have not money or I'm not paying the cost, but I'm going to the pharmacy, but with the thing that other will go to the hospital, and there will be no emergence, because if only as one individual does, definitely nothing will happen, right? That is everyone thinks, but what it ends up that everyone is doing the same thing. And that is what it says here, is that in the this is a game kind of thing situation where players choose their contribution level simultaneously same time, and dominant strategy is to choose zero contribution. Everyone is going to pharmacy, and therefore unique Nash equilibrium, it's a kind of equilibrium system in which all players choose zero contribution. Everyone is landed up with pharmacy, and that is what is happening in India and most of the cases here. Okay, so we formulated this thing, and so that is why we see it's a game. So we have basically public health perspective, that everyone should go to the hospital, go for test, diagnosis test, and whether you require antibiotic or kind of the prescription, you take this thing, and that way we can make our world drug resistant free. That is what public health wants. But the patient, the individual, thinks in a different way. Thinks that, of course, I'm doing the kind of only pharmacy. I hope everybody else in the neighborhood is going to the hospital. So if I do, there will be no wrong in it. Okay, so they want to free ride, and that is what the thing is. So free rider, and if you opted for self-medication, is a free rider gain benefit of resistance-free world, but they do not pay the cost of the proper treatment by going to the hospital. At the same time, individuals opted for proper treatment, they accept the cost of treatment, but they have only little incremental benefit, because also they say, if everybody is going to the hospital, then how much benefit I have? It's not that. I mean, population wide, there will be no resistance on the in the community. So I'm okay. So with this, so what we have done, I think math, I can exclude this. Maybe, yeah, I prepared for something. So here is the infection dynamics again, for, susceptible and wild bacterial infected people. And this is the resistant one. This is the self-medication. For example, let's look at this. Just forget about the equation. So this is a susceptible compartmental model. Here, once you get infected here, you have two choice. Either you go for treatment hospital or you go for self-medication. Okay. Both will survive, but at different rate depending on different parameter values, and they can also acquire infection, etc. Okay. So, but with this, we have a three important parameter here into the system: reduce transmissibility, because how much treatment is effective when you go to the hospital, rapid recovery, how long it will take to recover, and reduced mutation or plasmid transfer. So these are kind of the parameter that is important for this dynamics, because we'll look at the system with respect to these parameters. So, and here is the game. Now in the game, we have two options: either you self medicate or going for hospital treatment. And for both of these choices, you have certain cost associated with it. One is, this is, if you go self medication, means there is a probability of, imbalancing the selection pressure of thing, I mean community wide, and that relates some kind of a risk here. On the other hand, if you go to the hospital has certain cost here, and that depends on your income. Now here, both are basically perceived cost. Like, I'm an individual and I am thinking, what is the cost for me? Actual hospital cost might be very low. if you go to the treatment, go for the treatment, the medicine may be free for this thing. But I am thinking, if I go the hospital which is 10 kilometers away, I have to take the transport. I have to I have to take 1 day leave from my job, and most of the daily wage people, they will leave the money for that same day. So they do not want to do that. Okay, so that is all perceived, and it depends on your economy. So again, we relate this perceived cost with this economy here. Okay, so with this, and we have the develop some equations, which is very famous replicator equations in game theory, and of course our economical Cobb-Douglas equation is there, socio-economic growth, which also has feedback with some disease. Now with this, we have calculated the socially optimum self-medication. Again, we have been able to calculate how much self-medication community people do. Again, if we have 100 individuals in a community or say 1,000, what is the fraction of people can do self-medicate? If we go beyond that, then resistance emerge and become endemic in the population. So we have looked against 3 different parameters: treatment efficacy, etc. And it says that when treatment efficacy has low and the transmission rate is low, then there's a lot of individual perception. When there is no resistance in the drug resistance in the community, there is a lot of people choose for self-medication. But when it start increasing in the community, when we can notice, then of course we switch to the other option, and that is what reflected here into this thing. Okay, so this is another thing. I'm not going into this, but what we have seen here, treatment effectiveness. What is that? The higher treatment effectiveness actually lower the self medication, and that is what the thing. So here probably the public health people can inform individual, and that is what being doing in happening in India. From the government, there are kind of healthcare workers who are, they are not really medical practitioners, but they're whole healthcare workers. They're going to the remote areas in villages, and there even happens in, I think, sub-Saharan Africa, different places, and they're talking to people and they're saying this is the reason, that is how you should do, etc. So more information probably we need to reach out people to there, and information we have to supply, and that can change the scenario to some extent. Okay. So here is also another result which says that if expected utility as a function of success rate, if we know that if treatment is very effective, then definitely I'll go to the hospital treatment rather than going to this. Because of we don't know, that is why we take some different decision here. So that is being reflected. I'm not going into the detail of this thing, but the overview of the results that I'm going to play here. Now, public health intervention, of course, like for example, we have another term added here in the incentive part. Like if we have a higher incentive, and that's the function of resistance prevalence. Suppose if government help is kind of the rapid, like quicker help, or they are very kind of unresponsive in this resistance in the society. But quicker help, it says you can reduce this much. This is the area it says, and the area we have plotted against max help and sensitivity parameter means how rapid they can quickly they can take action. So the maximum help and quicker actions, of course, have reduced area. Higher it means we can manage the problem. Okay, so yeah, and of course another results is recovery from economic downfall, because we see it's a twofold problem. As we see that if we have plotted this on a kind of a usual subsidy, there is no subsidy, zero, then that is kind of the income rate here. But when there is a high subsidy, that is lower cost of the hospital, etc., treatment, then we have a economic growth, and that we have plotted with different RH. And as we see here, the means of this figure is that the changes in the growth of the income. So it means if we have a so xi, what you say this term, this xi zero means the max help is zero. Incentive from the government is zero. It means quickly the economic growth of the society can fall into the negative changes. It means it will, dry out their the resource for them. But if government help is there, so maybe at certain help with the parameter regime that we have considered, that probably it will never go below this thing in the whatever the hospital cost is. So government help is of course necessary, but quicker the help is of course the helpful. That is what it says. The timely and right amount of public health support may protect the resource limited population from the poverty and put back to the track of economic advancement. So with this, the summary is that self medication is a major contributing factor. I think I have told thing. This is the main problem of lower income and lower middle income countries. And our work demonstrate that financial risk protection of individual may effectively reduce the cost and reduce opportunity to self-medication and reduce the emergence of drug. And not only that, our model, the main thing is that our model, the interesting thing is that model can be improved to really calculate, for example, say, okay, this is the population size of the community, and this is the severity of the drug resistance and kind of thing. Then how much support, like for example, in terms of money, $1 support from the government incentive per individual, how much it helped to reduce in percentage of the, I mean, the probability of the emergence. So, so our model can be used to do that. We have published this thing in Royal Society Open Science in 2012. And with this, there is other work, but I'm not going to speak that. I think I'm not boring people with much more things. But the last one is I can thank you everyone. One of my PhD student, Bhavna, so she is now working with the CDEP that I said. So she did all this work. So this professor is from Public Health Foundation of India, and this is a professor from University of Texas who collaborated on this thing. And I got a grant from Science and Engineering Research Board India to execute this work. With this, I thank you everyone for listening this. And of course, if we have discussed, then I'd love to do that. Thank you.